Hello, everyone. I'll be speaking today about pre-pregnancy care and the pregnancy journey for women with spina bifida. We know and we speak a lot about fetuses affected by spina bifida. But what happens when these young girls become teenagers and reach adolescent age and finally decide to start on the pregnancy journey? So how do we go about it? I have no disclosure of interest, and this is what I'm going to speak today on how we optimize these young women, about the antenatal journey, what do we do for the intrapartum care, especially both obstetric and anesthetic considerations, and postpartum care. What is the prevalence of spina bifida? Well, we have data from the EuroCat study that mentions the rate is about 0.5 per thousand live births, but these are quite older data in 2003 to 2007. CDC reports similarly. In the US, you have 1 in every 2,800 births with people affected with spina bifida, and Hispanic women are at highest risk. In local data in Malaysia, University of Malaya Medical Center has similar rates with the international data about 0.5 to 10 per thousand live births. So this is a wonderful paper done in 2017 looking at the prevalence and distribution in a single major referral center in the country. So in the Embrace UK, I would like very much to use this very nice infographic, very nicely put, about how we should care for women who become pregnant, who have recently become pregnant, or who are keen to start a pregnancy. Always remember the holistic care that she is in the center and how we go around maintaining the best care for her. So before pregnancy, many questions would be there for women with spina bifida. Is it safe for me to embark on the journey? Will my baby also be affected? Will I be able to have a normal delivery? Can I take my anti-epileptic drugs? Will my urinary tract infections worsen? Well, the principles of care can be divided into 4. What is the clinical review that you will need to do for these women? How you adjust her medications, genetic counseling, and also general pre-pregnancy counseling care. Clinical review, assess her coexisting medical conditions. Many of them suffer from epilepsy, diabetes, urologic conditions such as neurogenic bladder, recurrent urinary tract infections, and also it's important to assess her venous thromboembolic risk. What about her past obstetric outcomes? Have she ever been pregnant before? Were there miscarriages? Were there previous children affected with neural tube defects? Menstrual concerns. It's not just looking about her choice or about her medical condition or surgery, but also about knowing that these women are known to have true precocious puberty because they have premature activation of the hypothalamic pituitary gonadal axis because of the presence of hydrocephalus or the shunts. So the growth hormone release gets altered. And in almost 15%, the average age of menarche is between 10 to 11 years old. What about sexual health? It's important to know the emotional and psychosexual concerns here because women with spina bifida, they have different mobilities, different parts of their bodies affected, but especially women who are bedbound or on a wheelchair and have difficulty mobilizing. I think what I would like to stress here is sexual assault, and that we need to always have that in behind because they're such a vulnerable group of women, and we should ensure that no one is taking advantage of them. Do not forget regular gynecological health, HPV vaccinations if they need to do smears, and also sexually transmitted screening if indicated. Medication review. Always remember balance the risk versus benefits. Continuing the medications is important to control any underlying condition. And it's important to have effective contraception alongside drugs which are not compatible in pregnancy. So what are the commonly used drugs that we see among women who have spina bifida? They have laxatives for chronic constipation. They use anticholinergics for bladder continence, antibiotics for recurrent UTI. So especially trimethoprim is commonly used, and it affects folate metabolism and needs to be avoided in the first trimester. Anti-epileptics, I think that's another topic as we all know, but it's important to review the medications, consider monotherapy, and ensure the lowest effective dose. Analgesia, most of them are in chronic pelvic pain or back pain, limb pain. Paracetamol is safe. Tramadol is suggested to be avoided in the first trimester because with that small risk in some case studies about facial cleft defects. What about NSAIDs? Yes, it can be used, but if a woman has difficulty conceiving, because we can have a discussion about should we stop the NSAID as it can delay ovulation. Folic acid, something very important and very essential. The NICE recommends 5 milligrams of folic acid to couples where one or both parents are affected with spina bifida, a woman with a previous pregnancy affected with a neurotube defect, couples with a family history of neurotube defects, women with pre-existing diabetes, and also women taking folate inhibitors. As we need to know that this wonderful paper, the MRC, had done multi-center RCT showing that women who are previously affected fetus, by having 5 milligrams folic acid, it reduces the risk of having a neurotube defect fetus by 72%. Genetic counseling. So there's developmental neurotube defects is not purely nutritional, not purely genetic. It can be other environmental factors too. And I think it's important that we explore all this. And what I would like to bring to your attention is this thing that we tend to see quite a bit nowadays when women have recurrent miscarriages. Patients are investigated very extensively, but we need to know that this thing known as MTHFR deficiency is commonly seen, and they come in saying that, oh, I have this gene, so what do I do? Can I get pregnant? But it's nothing to do with your risk of miscarriage, but knowing that it can affect folate metabolism. If a parent have one child affected by spina bifida, or if one parent is affected by spina bifida, the risk of recurrence in the pregnancy increases 1 to 5%. But if both parents are affected, the risk of recurrence increases up to 15%. Pre-pregnancy care, general recommendations by a MFM specialist, optimal BMI, the general things that we need to know: stop smoking, stop or reduce alcohol, vaccinations must be up to date, vitamin D, calcium, and the folic acid. What will be a specific recommendations? Always have a multidisciplinary involvement, because the care can be from the neurosurgeon, the urologist, psychiatrist, the neurologist, pulmonologist, and occupational therapy. Aim disease control not purely on the spina bifida, but the underlying epilepsy, diabetes mellitus, and obesity itself. Because it is in some of these women where mobility becomes a concern, it'll be difficult for them, to go and have exercise, and obesity becomes one of their effects. And also urinary incontinence, because of these uninvented events that occur, and a risk of their worry and they're embarrassed, they might not even go out for exercising. So there's a lot of things that we need to look at. Investigations, lung function tests, especially in women with severe kyphoscoliosis, at least a baseline renal profile and ultrasound kidney if women have recurrent UTI because of the recurrent insults of the infections. And always look at the desire for pregnancy and outline the plan. And ensure contraception. As we can see, we need to know someone's there's no reduced mobility due to wheelchair use, avoid combined hormonal contraceptives. Women on anti-epileptics mostly are fine, except depending on two things: whether the medication affects the efficacy of the contraceptive agent or vice versa. So if they are on anti-epileptics, which are enzyme inducers, it affects OCP, so implants, patches, and rings, and it can lead failure of the contraceptive action. But the other way around, for lamotrigine and estrogen-containing contraceptive, there's increase in seizure activity because of the fall in levels of your lamotrigine. In emergency contraception, IUD can be considered, but not favorable for all. So what happens in the antenatal journey? You screen the fetus for neurotube defects, bowel care, bladder care, musculoskeletal and respiratory concerns, seizure controls, VT risk, hypertension, and VP shunt care. I thought instead of going from your first trimester, second, and third, I thought it's important for us to look at this at a whole. So when you screen the first trimester for fetal neurotube defects, a risk, like I mentioned, 1 to 5%, we should offer first trimester ultrasound, followed by second trimester detailed ultrasound, should be under the care of the fetal medicine specialist. Aim to provide, if there's any defect, to detect the level of lesion, the type of spina bifida, any anocchiary malformation, ventriculomegaly, hydrocephalus. As we know that the MOM study, which is the role of in utero surgery, should benefit of in utero correction and the reduced need for shunt insertion in infancy. And this is by early detection, as early before 22 weeks, so necessary measures can be undertaken. What about bladder care consideration? So first, we need to understand what are common bladder problems that women with spina bifida have. They tend to have areflexia, which is absence of contractions of the urinary bladder, and non-functioning of the sphincters. So what happens if you can't contract and the sphincters don't function too well? There's a lot of backflow, a lot of stasis. This causes retention of urine, not from the bladder, ureters up to the kidneys, and this predisposes a risk of recurrent urinary tract infection. And what happens in pregnancy with the developing uterus? This further exacerbates the condition. What about detrusor activity? Yes, it can be in some small group of women, and they tend to have urinary incontinence. So how can we offer bladder and kidney health? So regularly monitoring for PET, midstream urine analysis and culture, a renal profile, making sure they have no proteinuria, do a kidney scan, and then it's also known that women who have underwent an augmentation cystoplasty surgery before are at risk of low potassium, magnesium, and B12 levels. And these need to be monitored and supplemented accordingly. What about bladder care? So most of these women are known to already be very familiar with intermittent self-catheterization. But again, in pregnancy, things can be a bit more tricky, especially when they reach the second to third trimester. And it needs to be clean. You need to give antibiotic prophylaxis. And consideration of oxybutynin can be in women with detrusor overactivity. It needs to be in a combined care with the nephrologist, especially if a woman has chronic renal disease. It's important to look at their renal function. Always work together with the maternal fetal medicine specialist, as there's a risk of preeclampsia and fetal growth restriction. And what about a urologist in cases that they have increased incontinence, especially in women with urinary deficiency? If they have difficulty in intermittent self-catheterization, you need to look back. It can be because the urostomies, there's a poor conduit drainage as the uterus grows, and they might need some revision. Ileal conduits can be obstructed or displaced. Moving on to bowel care considerations, dietary, high in fiber and increased fluid intake, offer stool softness or bulk-forming agents, exercise helps, and refer to a gastroenterologist, as some of these women, similar to a neurogenic bladder, has neurogenic bowel movements. And these women are at risk of bowel obstruction. So in that severe cases, we need to have an MDT to decide what will be the best onward care. Hypertension control. So what puts a mother at risk? A woman with prior renal damage, pre-existing hypertension, immobility, and obesity puts a mother at risk of hypertension and eventually preeclampsia under pregnancy. And role of aspirin should be considered, especially if you have pre-existing renal disease and hypertension. And you can better re-stratify these women at the first and second trimester, performing uterine artery Doppler. Now looking at VTE risk. We know the virtuous triad, stasis, vessel wall injury, hypercoagulability, reduces thrombosis. So looking at the RCOG-VT prophylaxis guideline, immobility and obesity and with pregnancy makes the women at risk. I think it's important to continually assess the woman throughout the antenatal period. And if she needs to be on low molecular weight, yes, I would put the mother on low molecular weight if depending on my assessment. Musculoskeletal considerations. So what are the orthopedic concerns here? Some of them have hip and knee joint, foot and rotational deformities. They can have lower limb contractures. What about ambulation? So if the lesions are above L3, they're mostly non-ambulatory. And if the lesions are L4 and L5, they still can ambulate. But what are the issues that can arise? The wheelchair dependence increases. There are more frequent hospital admissions, PT risk, pressure sores. Even women, if they are on crutches or just using walking aid, their mobility tend to deteriorate during pregnancy, but is known to improve postpartum. So what we can offer? Orthosis, wheelchair aid. If so, a women's on crutches and braces, we would strongly advise to consider wheelchair and upgrading their mobility safety, because with pregnancy and there is just to prevent risk of fall and trauma to them. Back and leg pain, consider wheelchair, bed rest, proper physiotherapy. Get the rehab medicine specialist in and to better manage their care. And early referral to an occupational therapy and physical therapy is good, so that you can also get your intrapartum and postpartum care, especially how to, if you need those aids during delivery. Respiratory concerns. So the kyphoscoliosis deformity is one of the concerns that we are worried because they are at risk of restrictive lung disease. It's important to have a lung function test, to look at the pulmonary vascular pressure, and an echocardiography at least once. In the second trimester would be ideal to do it because sometimes lung function tests too early, not too effective, and we're too late in your pregnancy, you might be even having difficulty to perform the spirometry. So we need to understand that gravid uterus can decrease the diaphragmatic activity and the spinal curvature gets more exaggerated and hence making it more difficult. Always remember review symptoms, shortness of breath. If they have an acute presentation, don't forget to rule out pulmonary embolism. In severe cases, there can be underlying pulmonary hypertension, and in women with chronic hypoxemia or type 2 respiratory failure, they may require non-invasive ventilation, especially after delivery. What about the ventricular peritoneal shunt care? So it's not a contraindication in pregnancy to have a CSF shunt. About 85 to 90% shows there's no shunt malfunction or revisions necessary, but it's important that we work hand in hand close with the neurosurgeon to look at the shunt function and position. It can be displaced due to the developing gravid uterus. So women with functioning shunts or mild shunt dysfunction still can have vaginal delivery with close monitoring in labor. However, if there's any new signs, red flag signs like headache, nausea, vomiting, or seizures, we should order an urgent MRI brain to look at the ventricular size or a shunt malfunction. What about seizure control? So, like I mentioned earlier, about 10 to 12% has underlying epilepsy, and 1/3 of them can deteriorate. There's a risk of sudden, unexpected death for women with epilepsy in pregnancy. So it's important that anti-epileptic drugs which are safe in pregnancy, not all, but those which are commonly used and needs to be monitored. And of course, the safety advice needs to be put in place. So what's the intrapartum management? So we should have a multidisciplinary team involvement and meet before these women. How you prepare for a delivery? It should be in a consultant-led unit. There must be a obstetric anesthetist or a senior anesthetist, team of a colorectal surgeon, neurosurgeon, neurologist available. You need to have a birth plan. Understand that some of these women, about 1/3, are known to have latex allergy or latex hypersensitivity. So you need to have a planned delivery, cesarean birth or a vaginal birth, ideally between 38 to 39 weeks to avoid emergency birth, and always having a required backup of the urologist or colorectal surgeons. So in vaginal birth is advised unless cesarean section for obstetric indication. We need to carefully assess, especially those with long-standing contractures of the lower limb. It can affect the pelvic obliquity and alter the pelvic floor. So even simple vaginal examinations can be difficult, not for us, not for the doctor, but difficult for the patient to move, and it might be painful. Pelvic organ prolapse. So women who have pelvic organ prolapse, vaginal birth can exacerbate it. So it's good to have a discussion with the women. What to watch out for? Positioning in labor in women who are non-ambulatory. Good to get your physical aids, like I mentioned earlier, from the occupational therapist. Blood pressure monitoring, especially those with CSF shunt. Kyphoscoliosis, you have the oxygen saturation monitoring. Bladder care. So, if they're an epidural or not epidural, sorry. In some, those mild ones, if they're an epidural or during prolonged labor, catheterization is important to reduce UTIs and educate hydration. And do not forget venous thromboembolic prophylaxis. Instrumental delivery are those advised for those with neurological defects because of the spinal dysraphism, there's reduced bearing down and they're unable to actively bear down. There's no need to shorten the second stage because nowadays there's unidirectional flow of your VP shunts, so that's not going to be a concern. C-sections are recommended for those with mothers with fixed adduction deformities or contractures who are non-ambulatory. And in those who had previous neck reconstruction or artificial sphincters placed, it's important to protect continence for them. What are the precautions you take in OT is proper positioning, VTE prophylaxis with the pumps. If you have a CFS shunt, you can have prophylactic antibiotics. You can pack before you make the incision. But of course, adhesion forming is there, which can lead to shunt failure or obstruction later. So if women becomes unwell, you may need to do a revision postnatal. What are the operative technical challenges? Because especially women have previous urinary or bowel diversion surgery, additions, anatomy gets a bit altered. Bladder augmentation surgery, there are a lot of anatomical variations. If they have a congenital renal anomaly, the way the ureters are and the placements can be tricky. So it's good to have a urologist and colorectal surgeon on standby during delivery to ensure to avoid unnecessary trauma or injury to the nearby organs. And in some cases, you may even need a classical uterine incision. What will be the anesthetic concerns and things that we need to do? So women should attend anesthetic clinic, especially with spina bifida cystica or occulta, those with neurological symptoms or suspicion of a tethered cord. So what do we need to make sure it needs to be done? Early assessment, baseline neurological examination, imaging either of an MRI or lung function test, look through the previous notes, get a consultant input, ideally an obstetric anesthetist, and a written anesthetic plan or a pre-labor analgesic plan. So if you can see the difference between spina bifida occulta and cystica. So in spina bifida occulta, the one on your left, you can have labor, epidural analgesia, and GEA is all usually uncomplicated, especially those with spinal cord tethering or dystrophism. We try to avoid spinal techniques to reduce the injury. And of course, in cystica, spinal anesthesia is contraindicated because there's risk of failure, injury, and patchy block. So epidural, if you're putting, it needs to be timed. The risk of the dural puncture is abnormal ligaments and there'll be abnormal spread, hence abnormal coverage during the surgery. Of course, there'll be technical difficulties, so using an ultrasound can able to locate midline, measure your depth of your space, and in some cases can also diagnose new onset spina bifida occulta. Epidural catheter is normally placed above the level of the lesion. Well, in some, it can result in insufficient perineal analgesia due to the sacral segment sparing. So in those cases, a second epidural catheter is placed just adjunct below the level of the lesion for the lumbar plexus or pudendal nerve block. What about general anesthesia? Of course, there's still a risk of difficult intubation. So risk of perioperative respiratory problems with severe thoracic kyphoscoliosis is essential, may require non-invasive ventilation and ICU care post-delivery. So neuroaxial anesthesia, wonderful paper, hot off the press, just in this year, August, about what happens for women with existing structural spinal pathology. Very, very nicely put in this wonderful algorithm about what do you do and when do you proceed with spinal anesthesia, epidural, or a neuroaxial anesthesia. So coming to postpartum, what are the principles of care? Most women have uncomplicated recovery. You have to be cautious because they can be worsening of hypertension, UTI, the shunt, relapse, or epilepsy. So medication, switch back to pre-pregnancy medications and which are breastfeeding compatible. VT risk, we need to understand the risk increases much more in the postpartum period, and if need be, to extend the period of low molecular weight heparin to at least 6 weeks. Breastfeeding, especially in women with kyphoscoliosis, positioning can be a challenge, and getting a lactation specialist is good. You can look at Lactamed, MGP guidelines, or bump on safety of all these medications. Mental health support. Remember, the journey itself can be emotional and for both the patient, the partners, family, and the healthcare. So having good support groups, and we have this IFCSBH, wonderful society, and our Malaysian society, which are there to help all women with spina bifida, and also their risk of postpartum depression. Contraception, like I mentioned earlier, but just to take note again, women on anti-epileptic drugs, look at the enzyme inducers. Women at VT risk, avoid estrogen-containing contraceptive. Condoms, avoid those with latex allergy. An intrauterine device may be difficult, especially in women with fixed contractures and those that were women where vaginal delivery is contraindicated or difficult. Well, to end it, my take-home message would be, it's women's right for childbearing, and to ensure it's a safe journey, it's a multidisciplinary care model. It is a high-risk pregnancy. Have pre-pregnancy care and counseling prior so you can provide a structure and understanding for a future pregnancy. And we need to still understand the small risk of neonatal uretube defects in the offspring. With that, these are my references, and thank you very much. Thank you for listening.